walk through some of the functional anatomy here. So, main goal is going to be to make gametes. We know that that's happening in our ovaries. We then need to transport those gametes to the site of fertilization, and then we need to pass them, because we are dealing with females here, to be not just fertilized, but after they are fertilized, that we can then grow our embryo into a new human. So how do we do that? So like I said before, we make our gametes here in the ovaries. The ovaries are going to get released out into this little hand-shaped structure here that we're going to call the uterine tube, okay? So if the uterine tube is the arm, the hand is what, or the fingers of the hand are what we're going to call the fimbriae, okay? So these fimbriae are these little finger-like projections, and they're going to sometimes, like at the time of ovulation, quite literally tap against the surface of the ovary. What they're here to do is they're basically here making a large kind of funnel shape so that when the secondary oocyte is released or ovulated, that it is caught and it is pushed down into the uterine tube, which, like I said, is going to be our site of fertilization. Okay. Now, if that egg is fertilized, it will then need somewhere to make sure that it gets all the nutrients it needs and the space that it needs in order to grow into a child, okay, or into an embryo, and then eventually into a fetus, and then finally into an infant, right? That is going to all happen here in the uterus, okay? Now, you'll notice that the uterus is drawn with these kind of wavy lines. Well, those thick pink wavy lines are typically going to be associated with muscle, okay? That is exactly the case of what is happening here in the uterus. The uterus has three main layers of tissue, where we have the endometrium, the myometrium, and then finally the perimetrium, which is on the outside, okay? This, or epimetrium rather, this endometrium is going to be this innermost lining here. Now, this is what is actually going to be shed during the menstrual cycle, okay? And the whole idea with it is that this inner lining of the endometrium is going to thicken over the course of the month and then be shed during menstruation when it is not fertilized, okay? But the reason it is growing and getting larger and filling up with all of these blood vessels and stuff like that is specifically so that if an egg is fertilized, it can land on this set of highly vascular tissue that when that embryo connects, it will attach to those blood vessels and supply that growing embryo with all the nutrients and stuff that it needs. So it will then attach to those blood vessels, or attach to that tissue, and then those blood vessels will fully attach to the growing embryo and generate what we call the placenta, as well as generating the umbilical cord, which we will use to furnish the growing embryo with all the nutrients and stuff like that it needs, okay? But that has to happen here in this endometrium. Now, the reason we shed that is because we're going to be growing this layer and it will get too thick. Some of those blood vessels may get stuck together, all kinds of issues like that, as well as over time, their blood vessels themselves may not be small enough anymore to where they're going to do that great of a job of interacting with the growing embryo. So what we do then is once a month, we're going to shed off that endometrial lining so that we can get rid of all of those blood vessels that we don't need anymore, so that we can then grow a new set as we are preparing for the next month's embryo. Because importantly, this ovulation event also only happens once a month. Okay, so there's no need for us to hold on to all of this endometrial lining for 3 or 4 weeks or more if we're not going to be seeing another egg anytime soon either, because it's just going to be growing really for no reason. So it doesn't make sense to put all that energy and stuff like that into that. So we shed it off to the point where we're going to use all these muscles here to help kind of grind that endometrial lining against itself so that we can use that to get rid of it. The grinding and the squeezing of the placenta to kind of grind away the endometrial lining that we're trying to shed is oftentimes, or is why menstruation is accompanied by menstrual cramps. That's because the uterus is squeezing itself so it can push out all of that unused endometrial lining, okay? Now, at the end of the uterus, we're going to have this region here, which we call the cervix. This is basically going to be the opening to the lumen of the uterus, okay? if you've ever heard or been around someone undergoing childbirth, and they're calling out, okay, no, they are 6 centimeters or 5 centimeters or something like that. What they're actually measuring is the size of this opening of the uterus. Because once we've reached that 8 to 10 centimeter mark, that tells us that the head of the child is now basically about to enter the actual birth canal itself. So we have now basically got the child lined up and the opening is now clear through the uterus. So then it will then pass through the vagina as well. Okay. But that's what they're checking here is this region of the uterus. So here is what we would call the cervix. Is going to be this kind of nose down region of the uterus. Okay. Now, then we have the birth canal, which is the vagina. Okay. This is also the pathway for fertilization. So intercourse is, of course, going to happen here through the vagina where the sperm can be released here into the vagina. And then finally, it will pass through the uterus and into the fallopian tubes to fertilize the egg. Okay. Now, we can also see some other features here, some of the other organ systems. So when we talked about the urinary system, we talked about the closeness of the female urethra to that of the anus and how close in proximity these are. And that's a big part of why females are much more likely to have something like a urinary tract infection simply because of proximity. And we can see that in this kind of medial view here. Okay. Oh, I didn't talk about external. Okay. Now, all of that so far has been kind of our external anatomy. We also do have female external anatomy here, where we have our three major structures, which are going to be the clitoris here, which is this band of erectile tissue located anteriorly, kind of just inferior to the pubic symphysis, so centrally located underneath that bone. Now, protecting the anterior surface of that pubic bone is actually going to be this bit of fat right here, which we're going to call the mons pubis. Okay, so this is basically just going to be some cushioning for that pubic bone, which does extend itself somewhat anteriorly and thus could cause problems that way. So it's protected by a little bit of fat here. Okay, now then we also have the genital folds here, which are basically going to be the labium minora or labium minus, and then the labium majus, which is going to be this outer fold here. These are basically here to protect the openings of both the urethra and the vagina from external sources, whether that's bacteria, fungi, or whatever like that. That way there's at least some pathway that things have to move through before they get access to the inner body. Now, here we can see in this dissection, we can see a few things. So here we have our uterus. Now, the uterus is going to be held in place by several different structures, okay? Namely, it's going to be held in place by the round ligament and the broad ligament. The broad ligament is going to be this structure here that kind of wraps all the way around, kind of looks like these little bat wings. And then we're going to have the round ligament, which are basically going to be these stronger ligaments out here on the sides. Now, these are the ovaries, and you can also see the uterine or fallopian tubes here that are connecting the uterus to those ovaries up here. Now, because we were looking at the front, we can see this larger structure here. This is the urinary bladder. So once again, here's the broad ligament. Like I said, it kind of looks like these bat wings or almost like a cape that someone's kind of flailing out. Connecting the ovary to the uterus, we also have the ovarian ligaments here, but we also have ovarian arteries and veins, which are going to be providing the blood vessels and support to the ovary up here. Now, we can also see the fingers of the fimbriae a little better, and we can also see that hand region that wasn't labeled on the previous picture that we'd call the infundibulum. All right, now here we have a cross-section of the ovary. Now, once again, our goal with the ovaries is going to be to secrete a mature secondary oocyte, something we might call an egg, okay? Now, to do that, we're first going to start with these primordial follicles. Now, primordial follicles are going to be held at the end of meiosis 1, okay? So they're going to be held in place, and they're going to be kind of stuck kind of in this position here where they have not divided yet, okay? Now, over time, these are going to mature. They will complete one division, and then they will move on into what we call these primary follicles. Now, the primary follicles are now going to be growing some cells around the outside, okay? Where we're going to have this little crown of cells around the outside. Then they will form into what we call a secondary follicle. Now, these secondary follicles are going to have a increased thickness to these layers of cells around the outside. We're also going to see this special layer of empty space around our actual follicle or oocyte cell here in the center. Then we're going to form what we call an antral follicle. Now, the antral follicles are going to now be connected to one of the sides by this new group of cells, but we're also going to be changing this space that we saw before. So now we're going to see this division. We're going to have some cells that are close to the oocyte, and then we're going to have some cells that are further away. We're going to have this space in the middle that we're going to call the antrum, okay? Now, over the course of a month, these cells will continue maturing and continue maturing and continue maturing until eventually they release or are found in what we call a mature follicle, okay? Where this cell is now ready to go. It has had all the nutrients built up in it and things like that it needs to where it can now become a mature egg that is now ready to be fertilized. Now, importantly here, even before it is ovulated, it is still held in this division. It has not yet divided into or had its last part of meiosis II completed. It has not completed that. It's still waiting to do that. That second division will only occur if the cell is fertilized. So only once a sperm cell has hit it will it then divide into its final two daughter cells, at which point you choose, or it is randomly chosen, which of the two daughter cells that are possible from this particular cell it will then happen, okay? So it basically divides and then it will become the embryo. But that only once again happens if it has been fertilized. Okay. Now, when the cell is released, we would call that ovulation. This is going to happen at day 14 in our menstrual cycle. Now, once the cell has been ovulated, we're going to need some stuff. Okay. Hormones are now going to change quite a lot. The hormones are now basically going to try and, or are going to need to make sure that the endometrial lining is set up and prepared for a possible fertilized zygote or possible fertilized embryo, which means we're going to need to increase the amount of estrogens and progesterone that we are secreting. That is going to happen from here in what we call our corpus luteum. Our corpus luteum is going to be a gland which is made from the rest of our mature follicle. So when we ovulate that oocyte, we're going to be left with the rest of that follicle here. That follicle gets turned into our corpus luteum, which is a short-lived gland, so it's only going to live for a couple weeks, that is going to secrete lots of progesterone, which is going to cause our endometrial lining to thicken and prepare for possible implantation of a zygote. Now, if the cell is not fertilized, this corpus luteum will degrade and become what we call this corpus albicans. So luteum means yellow, albicans means white. Okay, so it will degrade. It will become what we call the corpus albicans, which is basically saying that it's going to be dying here soon, at which point it will be eventually reabsorbed. So primordial follicles have a single layers of cells around the outside. They're very, very thin. The primary follicles that we have as our next step are going to contain that really small space, which we call the zona pellucida. We have our primary oocyte in the middle. And I said earlier that we get that special layer of cells around the outside. Those are going to be our granulosa cells. Now, once we move to the secondary follicle, you know we have reached secondary follicle when you see this new layer of cells around the outside that we're going to call the thecal cells, okay? So the thecal cells will now form around the outside. We're still going to have this layer of granulosa, and now we're going to have this large empty space around it, which we're going to call the zona pellucida. Then we form our antral follicles. So primary, secondary, antral. The antral follicles are now going to have this special growth of these sort of granulosa cells around the outside, which we're going to call the corona radiata. So corona means crown, radiata means radiant. So we're going to have this basically crown around our primary oocyte here in the center. And then the special fluid, which we found in the middle before, which we also did not have before, we are going to call the antrum. That's why we can call it the antral follicle. Now, finally, we're going to have our mature follicles. So from primary oocytes or primordial follicles to primary follicles to secondary follicles to antral follicles, and then finally our mature follicles. Once we get to the mature follicles, now we have what we're going to call the secondary oocyte, okay? We reach this point only after we have finished completing meiosis 1, okay? So we finished that first division where we now are kind of in this phase, okay? Where we have 2 copies of every chromosome inside this cell, but the copies that we have are related to each other. They are either a maternal chromosome or a paternal chromosome, or they are the mixture of the maternal and paternal chromosomes after crossing over. So we are now left with this one. So we have gotten rid of basically half of our possible genetic possibilities at this point, okay? At that division, so at the completion of meiosis 1, we're going to form what we call a bar body or a bar cell, which cannot be fertilized. Those are just simply going to be degraded and broken down, so we have access to those components and stuff again. But these are going to be held in that second meiotic metaphase. So when I said metaphase, remember that's when those chromosomes are lined up in the middle. So they are basically ready to divide, okay? Because these cells are, or these chromosomes are lined up in the middle and ready to divide, it is ready to go. So this cell is completely mature. If it is ready to ovulate the secondary oocyte, at which point, if that secondary oocyte is fertilized, it's made contact with a sperm cell, then it will complete the second round of meiosis. So basically, those chromosomes will then pick a side, it'll pick a side, and then it will be done, okay? Now, then like I said, it would form the corpus luteum. So luteum means from yellow. This is made up of that antrum that we saw before. This is now going to start pumping out lots of progesterone, lots of estrogen. So this is also why after ovulation, you're going to typically see, or you will see a hormone change, at which point sometimes you can even see behavioral changes brought on by some of those hormonal changes. Then we end up with the corpus albicans. This is basically corpus luteum has regressed. It's essentially going to be the leftover scar of that corpus luteum. Eventually, everything here will be reabsorbed. So most ovaries are like, if you were to take an ovary and do a cross section, you would see a little bit of everything. You would see some primordial follicles, lots and lots of primordial follicles. No one is going to make new primordial follicles after they've been born. All of these primordial follicles have already been made by the time you are born, okay? So you basically have made all of the things that can become eggs already before you're born. And then over time, some of those will mature and go through each of these phases. So when you do a cross-section, you would actually see various groupings of cells at essentially various points in this progression of things at any given time. Now, only once puberty starts will we actually see the progression here. Like that is only once puberty hits will we see the maturation of some of these cells where they're going to start getting moved through. This is also going to, of course, come with hormonal changes where we're going to see upticks in gonadotropin releasing hormone. Gonadotropin releasing hormone causes the release of follicle stimulating hormone. Follicle stimulating hormone is going to cause us to make or mature more follicles. So we're going to go from more primordial follicles to more primary follicles. We're going to go from more primary follicles to more secondary follicles to more mature follicles, and more mature follicles are going to lead to more ovulated oocytes at the end of the day, okay? Now, that is also one of the reasons why follicle stimulating hormone is actually one of the major drugs that people are going to take whenever they are trying to get pregnant. Okay, so whenever people are taking fertility medication or fertility drugs, one of the biggest ones that they're going to make or take are going to be drugs that either stimulate the release of follicle stimulating hormone or are going to simply mimic follicle stimulating hormone. And that's simply because this is going to cause the release, or it's going to cause more follicles to mature and also cause more mature follicles to be ovulated. So instead of just releasing one a month, say someone might release multiple cells a month now because of the massive increase in follicle stimulating hormone. This is also why folks that are undergoing fertility treatments are far more likely to have twins or triplets or more, simply because they're going to be making that many more of these mature cells. So it is more likely that they're going to release more than one cell at a time, which means fertilization is going to be easier that way and lead to more pregnancies. Okay, but also oftentimes more multiple pregnancies as well. Okay. Now, luteinizing hormone is going to be different because it's going to do exactly what it says it is in its name, luteinizing. What's that going to cause? It's going to cause us to make the corpus luteum. Okay, so luteinizing hormone is going to basically uptick and say, hey, we need to turn that mature follicle into a corpus luteum so we can start making progesterone and estrogen. Okay, that one is going to cause us to have ovulation events. Okay, so that's when we're going to see big upticks in luteinizing hormone. Is because these are going to cause ovulation. Oftentimes, when someone is undergoing a fertility treatments, they'll also sometimes take luteinizing hormones at very particular times so that they can cause the release of all of those mature cells that they've been making. That way we can kind of more structure exactly when that's going to occur. Typically, though, this is all going to be regulated by our hypothalamus, where we can make sure that these things are all at their normal levels, at which point this will all happen. We'll release one mature follicle a month, at which point we're going to have our typical kind of 28-day menstrual cycle or ovarian cycle. Now, the first part of our menstrual cycle is actually going to be